My name's Kurt. I'm a physical therapist that works in Associate Health, and we're going to talk a little bit today about the Banner Mobility Assessment Tool. This is a piece of nursing assessment that is going to become part of what we're doing to remain compliant with the new New York State legislation on safe patient moving and handling. At Thompson, we've been doing a lot of things over the years, but this is a piece of what the nurse will do upon admission for assessment of the patient to determine what type of equipment they would be using for safe patient moving and handling. So the Banner Mobility Assessment Tool, or Bmat for short, was developed by Banner Health, by nurses and an occupational therapist, and it is a series of questions or queries that would be done as part of your normal admission, except what we've done now is we've built in McKesson a system to capture those results and then drive whether or not the person would use a total lift, a sit-stand lift, a manual stand aid, or could potentially walk with supervision or independent. So Lori, I'm going to have you sit down, or lay down, sorry. You can leave your shoes on, that's fine. And I'm going to take you all the way through these questions, and we've drilled this down from a very complex set of directions that are very busy, so that we can make this an easier series. If I had given this to you as a nurse and you said, I've got to read all that in order to decide what my score is, you would have probably not been too cooperative with that. It would have been time consuming. So we've drilled that down with Lori's help, and we have created a very succinct document that will help us to record what the person's mobility needs are. So I'm going to go through this all the way through the 4 stages as if you had no trouble, but we're going to kind of talk about each one as we go along. So the first query I ask is, can you move from that position to sitting on the side of the bed with your feet on the floor? So you can roll over onto your side, and you're going to push yourself up and sit. And we want to try to make sure the patient's feet are on the floor so that they've got a firm base. So our first answer would be yes, you can do that. That allows us to go on to the next question. The next question would be, can you reach across midline and touch my hand? So with your left hand, good. So we only need to do that with one hand. You can do it either way, but that's going to challenge your dynamic sitting balance so that we have an opportunity to see how you move while you're, or if you can maintain your balance while you're moving. Once that's met, the next query would be, with one leg, can you kick your leg up straight and point and flex your ankle for me? Good, and then up and back, and then we're going to do the same thing on the other side, and I'm just guarding in case you're unsteady. Good, and that then tells us that there's enough leg strength in the quad to be able to potentially straighten the leg against gravity. Okay, so that tells us that we're going to be okay. If one leg can't come up, then it would stand to reason that leg might not hold you in a standing position. The next thing is you're going to stand forward. So you can come up, okay, and I'm going to kind of pause here for about 5 seconds and just assess how your balance is. You're solid, no problems, you're not wavering. I might say, are you feeling dizzy? Are you having any discomfort or problems? She says, no, I'm doing okay. That's our 4th yes. And then our last query is, can you step forward with one foot, put your weight on that, and then come back, bring your feet together, and then repeat with the left leg. Good, and come back. So that would then make you a mobility level 4, the highest level. 1 would be the lowest. You would then be able to be independent to move around your room or as per the nursing plan, so that if you needed supervision, we would want to document that. If you were struggling, you could also use a walker if you had to. Okay, so that's kind of the whole thing. It's pretty quick. It takes about 60 to 90 seconds if I'm not talking so much, and the person kind of moves through if they have got no restrictions. There's a couple good things that will happen here. In nursing, you guys may have patients that are with you on the floor for a day or 2 or 3 before therapy gets referred. And we need to make sure that nursing can assess them to share that information with the patient care tech or somebody from diagnostic imaging or anybody else, so that we would know how Lori would be able to transfer. There's other times where we may have somebody who's up moving around independently, and there's a standing order as part of a group of orders that PT would automatically get a referral, and they get there and the person's up walking around and they've wasted their time to come for the referral. So our goal here is to try to also streamline how we're utilizing our support services. Okay? So any questions about what we've kind of worked through there so far?
Not yet with that kind of person.
Okay, good. So let me have you lay back down. And now we're going to go through several different things where there would be a difficulty and how we might respond to that. Okay? So again, if I ask Lori, can you turn over on your side and come to sitting, and she tries to do that, she struggles a little bit and really can't do it independently, my assessment is done, and I'm going to document that you're a total lift. Okay? Because the answer to the first question is, can you roll to your side and come up to sitting on the side of the bed? And if she can't do that independently, that's going to be indicative of the need of a total lift. Okay? Now, a couple things that have come up in our discussion. If Lori had a shoulder injury and she'd had surgery and she was in a sling and that was limiting, I can assist with some rolling. We might be able to let you use the side rail, or I can even use the motor on the bed to bring the head of the bed up to use that as an assistive device. What we're trying to get away from is the nurse as the healthcare crane. We don't want you getting in and physically lifting the patient, because that's where we're still experiencing a lot of safe patient handling injuries as we work with folks. So if Lori can roll to her side, so now we'll assume that you can do that much, and you can either press yourself up, I could even maybe come in and just give a little bit of an assist here if it's needed, swing your feet around, and again I want to try to make sure her feet are on the floor. Then we can, and Lori may need to scoot forward, I can adjust the height of the bed a little bit, but I don't want to get you so close to the edge that you're going to fall off, because that would obviously be a problem too. So now we get to here, and if Lori is wavering around, she's got poor balance, if I have to sustain her balance and hold her, then that's going to be a problem for us trying to come forward. That would also be grounds for you can't maintain that. Even before we get to the cross midline reach, we would stop here and say that you're again a total lift. Okay? So the first two questions are getting from the bed to sitting, and then from sitting and reaching. So that's we had a limited number of characters that we could build that first mobility level, and we had to break it into two questions. So there's kind of a 1 and a 1A. So if we get to here and there's a problem, again, and the answer to that is no, you can't do it, we go to total lift. If the answer is yes, we look okay, and I have you reach again across. And if this is where she has trouble, then that would also be total lift.
By total lift, do you mean Hoyer lift?
Yes, okay. That's a great question, and I say total lift because we don't have any Hoyer product in our facility. So if somebody was to go to our lift, they're going to see a Medcare lift, and Hoyer is a name brand. So I use the term total lift, but it is interchangeable. A lot of people still say Hoyer. It's what we would use with the full body sling that goes over the full length of the back. Proper fitting for that sling is the top of the sling needs to come to the top of the shoulders. The bottom of the sling needs to get all the way down to the bed, or kind of the top part of the rear end below the belt line. And there should be at least one hand's width of material on either side of the patient's trunk. That's how the sling is fitted. But that's a good clarification, because a lot of people do call that a Hoyer. But that's our total lift for a person who can't bear weight. Okay? So then we would get to where we ask Lori to kick a foot up. Now, so kick up, but you can't get either leg fully straight, okay? Or as she pulls a foot up, she loses balance, okay? Then that would be a problem for what we need to assess, that she wouldn't have enough leg strength to be able to stand. That would also be an indication of the query to go back to the total lift, okay? So what we're trying to do here is to not have where we have mod assist of two staff pulling Lori up off the side of the bed where we're kind of the lifters, okay? If Lori could raise one leg up, okay, so she can get this one up and move your ankle back and forth, good, and that looks good, but this leg doesn't come up as well, she struggles with that, then that might be an indication that we should be looking at the mechanical sit-stand lift, okay, ready stand. There's a lot of different products, again, that people would call. All of our products are Medcare. So that would be the Medcare sit stand with a belt that goes around the waist, and then we would hook her up to that. If Lori could kick both legs, okay, now so you can kick all the way up, and you flex and extend, good, and back down, and then the same with this leg. Now we know that your legs are strong enough, and now we try to go to the next phase. But as you try to come up, she struggles and can't get all the way up, where she kind of falls back down. I can help a little bit here, but my goal isn't to be the whole lifter. So if we run into that problem where I assist a little and it's still not going well, I can introduce our manual stand aid, which is the white frame with the black paddles on it. There's no power, no sling. I would bring that in, I'd lock the brakes out, and then Lori would reach forward, and if she could pull herself up with that, I can put the paddles back into position so she can kind of sit and is locked in on that. We are then able to say that she would transfer with the manual stand aid. If she tries to pull up and can't do it, then we would still go back to the mechanical lift and have that lift pull her up. Okay? The manual stand aid is very nice because it works well as a grab bar, and it also works well for the patient who can't pick their feet up and move. So instead of us trying to torque and drop them in the chair and hope that it all goes well, where they're, the butt's facing this way and the feet are facing in the wrong direction, that manual stand aid allows us to rotate and get the feet into good position before we sit down. Okay? Lastly, if we come forward and now you can stand, and Lori is able to come up, but she's a little wobbly, okay, uneasy, unsteady, but she's not dizzy, she's not going to pass out, but she just doesn't feel like she's got enough strength to hold her balance well, we could introduce a walker. And the walker might help you to keep your balance, okay? Again, we're going to hold for about 5 seconds, and then we're going to look at the moving of the feet with that forward step. We could use the walker for the forward step as well. If she's the type of patient that can stand but can't physically move her feet well, we'd consider going back to the manual stand aid again. Okay? So we're not trying to take away your clinical decision making as a nurse. We're trying to use some cut points and some checkpoints to make sure that we're doing things similarly and that we're able to give the information back to the patient care tech or the diagnostic imaging tech or Neil in transport who's coming up, so that they have an idea of what equipment they might need when they get back down to, if it's DI that they're going to, if it's somebody that's coming in a wheelchair, we have an opportunity to run through kind of the phase where you would start with the kicking because they're already sitting, and then you would go from there. Okay? Mm-hmm. Do either of you have questions? No. You're okay too? No, it's fine. No, ask them. Because other folks on the video, they're going to want to hear it too. No, that's fine. We can let that run.
Yeah, I was kind of just wondering, confused patients.
Okay.
But they're strong, they don't follow commands. They're just kind of up and where's that assessment
thing?
Well,
so that might be more of a supervision, right? Because if they can't be up wandering around, because that could potentially be unsafe for them wandering somewhere or being somewhere where they shouldn't, we can still follow the same thing. I think if they're not able to follow your commands or your instruction, that's where you may have to use more equipment than you might otherwise think. Not necessarily total lift, but you might want them to be in that manual stand aid so that if something happens, the equipment is catching them, not us as the caregiver.
So it sounds like that manual stand aid might be kind of the go-to thing.
Yeah, that's going to be the bridge. Yeah. And that's the point that's come up, is how many do we have? Do we have enough of them? And Hazel and I have been navigating the building, looking at what we have and what we think our need's going to be. And that piece of equipment is going to probably be on a wish list, so that we have at least one in most of our areas for that very purpose. And then looking at, what challenges does that bring? For cleaning it and storing it and all of those things. So this is going to be ongoing. We certainly need the input from all nursing staff, all the patient care techs about what's going well and what we still have opportunity with. Okay? Mm-hmm. But that's a good question. It's not that you can't help, we just don't want you to help as hard as you used to. And one of the nurses earlier asked today, does this mean that moderate assist of 2 staff is going away? That's my goal. Because if I'm pulling with moderate assist and another staff member is pulling with moderate assist, the patient's not doing anything. And I'm just lifting them up. Mm-hmm. And that's dangerous for everybody involved. Okay? So, we've got these challenges in healthcare. We've got bigger people than ever before. People who are in the hospital are generally now sicker than they've ever been because we're really trying to manage people in their home setting, long-term care, only the sickest of the sick are staying in the hospital now, which means our demand is going up. And we've got to make sure that we're doing things differently. Okay?
Mhm.
Yeah, you can stop that.